helpful to have a general knowledge of what the treatments are for valvular heart disease. And they can fall into 4 different categories. So let's start with number 1, do nothing. And do nothing isn't really do nothing. It's a program of surveillance that a doctor may lay out. Maybe that valve isn't bad enough to do anything right now. It's leaking a little bit, but the treatments aren't benign. They carry risks. And if the risk of that little bit of leakage is less than the risk of the treatment, surveillance. We do that for a period of time. Some valve disease can be treated with medication. This tends to be when a valve's leaking rather than when it's blocked. So if a valve is leaking, there are medical therapies that we can put a patient on and treat them with medication for a period of time that's combined with surveillance. And under medical therapy, the heart can get stronger. We can alter the loading conditions, lessen the amount of leakage of that valve, and allow the heart to get stronger or go longer before we need to pull the trigger to intervene and do something about that valve. Now, if we're going to intervene and do something about that valve, traditionally that thought has been surgery. So let's talk about surgery first. When we talk about surgery, that can fall into 2 broad categories. 1, fix the valve. 2, replace the valve. And those have different implications. If we're talking about aortic valve disease, we are just now entering the realm where we're starting to fix more and more and more aortic valves. But for years, and still prevalently, the treatment is replacement of the aortic valve. The mitral valve is a much more complex valve. A lot of different things are controlling whether or not that mitral valve leaks or is blocked. So repair plays a much more prominent role in the mitral valve. We can put rings on that lessen the diameter so that the leaflets can now meet in the middle again instead of meeting out here. If it's a problem with the chordae tendineae that's broken, we can replace that. We have a lot of repair techniques for mitral valves. If one part of the mitral valve is badly destroyed and the rest is working, we can actually take that part out and repair the rest so that it comes together. How we get to the valve to fix it frequently gets confused with the fix itself. And there are 2 different issues. The principles of repair and replacement stay the same, whether you access that valve through a median sternotomy, which is an incision through the breastbone, a small incision between the ribs over on the side, which some people might call port access, whether you use port access and you use a robot to help you throw the stitches. Those are all matters of access, not matters of repair or replacement. So don't confuse those 2 things. Issues of access have to do with short-term healing. Maybe a smaller incision heals faster than a larger one. Maybe one hurts less than the other, but they have nothing to do with the repair that we're affecting.